One of the most common questions I get over the internet and in conversations with people who've recently been diagnosed with RSI is, what kind of doctor should I see? And people think there's a kind of doctor that sees RSI, and I have found in experience that it's not so much the kind of doctor that you see, but the doctor himself or herself and their understanding of repetitive strain injury. So, here to explain and help us understand this better is Dr. Robert Markison. He's a surgeon with 40 years of experience in hand surgery, clinical professor of surgery at the University of California, San Francisco, and a very good friend of the show. Welcome back, Dr. Markison. So how do you think I'm doing here answering that question of, not so much the doctor, but the attitudes of the doctor and the skill of the doctor and how did I do?
I think you did great. It is a holistic approach. But without arrogance or false sense of arrival, I do think you should start with somebody who has an MD or a DO degree, who is really skilled and in fact licensed in their specialty. That doesn't diminish the power of an acupuncture and other medical professionals who are esteemed, treasured, and valued. But you want somebody who really has a working knowledge of biochemistry, cell biology, physiology, form, function, fit, failure avoidance, drugs, drug side effects, drug person, drug food side effects, who can take a very, very detailed history. That doesn't happen in 5 minutes. Typically, occupational medicine physicians are excellent choices because they have a broad experience with everything from toxic exposure to RSI. Another good choice is physical medicine and rehabilitation specialists, especially those not given to prescribing too many pain medicines and all sorts of drugs for pain. But if the patient expresses him or herself early and says, look, I'd like to try, if possible, a broad, holistic, effective, non-pharmacological approach, no reason why a person of reasonable humility in the practice of medicine would say anything but, yeah, let's do it. There are things that will probably help you.
Just for the record, I have never recommended that someone see their acupuncturist. I mean, I like acupuncture. I think there's many wonderful practitioners out there, but just as you say, repetitive strain injury is really complicated. You have told me in past conversations that when you were deciding whether to go into heart surgery or hand surgery, you were advised, if you wanted complexity, to choose the hand. And again, I hope I got that straight. But in past conversations, in addition, you have told me that most doctors don't get a lot of training in the upper extremity, despite the fact that it's the #1 occupational injury. So when people are seeking, are there hints or signs? I mean, one of the things that you said that I've always treasured was, I'm a surgeon, I love doing surgery, but I also love keeping my knife in its holster. You're not so in love, enamored with surgery that you're going to do it unnecessarily. And I thought that was a really good sign. So are there other things that people can think about when they're searching?
Well, yeah, again, not only would you like to have a physician who has expertise and experience and a positive track record, but you'd also like to have somebody with a tight, responsive, capable network of referrals. So you don't, as a doctor, need to know 10,000 other doctors, but you would like to know that you have a hand surgeon with adequate experience and a well-tempered scalpel that, again, stays in its holster most of the time and can look at a person. Furthermore, you want to know a neurologist whose boards include electrodiagnostic medicine, who can do electrodiagnostic studies carefully from neck to fingertips. It's not a picnic, but it's not horrible, and it may be necessary to make sure that the world doesn't all look like carpal tunnel when it's coming from the neck or perhaps other combined regions. So the other thing is you want to have that person who has access to an internist if it's very obvious that you may have other problems that are primarily causative or contributory. And that would even include an internist who's an endocrinologist. or an internist with boards in rheumatology. Because, for example, people with very, very cold hands, Raynaud's as we call it, they turn whitish and bluish. 15% of them have associated rheumatological conditions which need to be addressed, ranging from lupus to other things. And so kind of the world of medicine, like the world of anything, is connecting apparently disparate domains of knowledge in a coherent and beneficial way. And so somebody comes in with cold hands, you don't stop there. You think, okay, good. Is there a rheumatological condition, including a dense family history of cold hands, and have others in the family had problems with strain based on chronic low oxygen levels, hypoxia? And so you're looking at someone who kind of has a prismatic spectral surroundings of high quality specialty referrals. And it doesn't mean you have to go through the whole gamut of everything, including a cardiac treadmill test, but a good doctor knows when it's over his or her head, needs a little bit of phone a friend and figure it out.
You know, you mentioned something earlier, Dr. Markuson, that I would like to point out, fingertip to shoulder blade. So if your doctor, in my opinion, the competent physicians look at you and give you a clinical exam, look at the neck function, look at the arm function, the ranges of motions, they would touch you to notice whether you had cold hands. And these examinations can take an hour and a half, an hour. I mean, they're not the kinds of things that you blitz through. But I think that's what it can take sometimes. Am I right here?
Well, you're absolutely right. I mean, obviously, I'm also a qualified medical examiner, independent medical examiner, and agreed medical examiner in contested work comp claims that have gone on a long time without a proper, complete physical diagnosis and industrial and non-industrial, non-work related history. And so, case in point, last Friday, 7,000 pages of medical file from 4 different Kaiser outlets, and treated, you know, compassionately by nurse practitioners, medical assistants, and physicians assistants, but no kind of kernel of truth, early examination that was complete enough to truly make work-related, non-work-related diagnoses, prescribe a treatment plan that might have spanned 5 pages instead of many thousands of pages. And so the sadness, and in this case, a very worthy woman who had 7 employments, 6 workers' compensation claims, and 9 discrete involved body regions, and I'm sort of the guy to put the puzzle parts together. It was very clear that all she really needed was a very detailed history and very detailed neck to fingertips physical examination to contain time, expense, and misery.
So you're, in addition to being a great doctor and teacher, you're a detective.
Probably true. I mean, I'm looking all the way across the specialties of epidemiology, who has what, why, and when. 1989, 210 Newsday newsroom employees with RSI met internationally at the University of Michigan to talk about epidemiology, then ergonomics, and then conditions which were neurological or musculoskeletal, and then reasonable treatment plans. And this RSI stuff didn't begin yesterday.
You know, one thing I was talking about somebody about, remember when the personal computer was first introduced? There was a chart, there was a graph, and the rate of RSI went up with the popularization of the PC. It was uncanny, and I can't remember where I saw that, but I did make that connection, and I was thinking, you know, these tools are leading to some not so great physical results.
It's true, and we've been over it. And the IBM PC Junior came out in 1982, Mac 128K in 1984, and various computers just hitting the desktop, and so we're now single tasking, and now in a condensed space with subpar ergonomics as people work at home in the current COVID viral pandemic. And so I'm seeing accelerating arthritis, aging kind of accelerating. I'm seeing accelerating carpal tunnel. And a few times within the elective surgery operating room shutdown in March and April, I had to urgently release carpal tunnels and justify it as emergent surgery because people could not put bread on their table as they thrashed along hands-on keyboarding all day, and obviously needed to have relatively acute decompression of carpal tunnels, sometimes tendons, trigger digits, and so on. And so now we're looking at a real kind of home-based condensation with remote work in information economies. And so there's a little bit of a challenge going on where, if anything, the person who's suffering has to be very aware of maybe fundamental changes, voice recognition software, foot pedals, those kinds of things, proper keyboards, vertical mouse, all of these things, in addition to finding a doctor who's willing to take the time, frankly, mostly uncompensated time, to figure it out and do a real detailed picture from the get-go of what's going on. Early detection, early comprehensive diagnoses, early treatment. That's the key to all of this.
Thank you, Dr. Markuson, and thank you for being that kind of doctor who does take the time and clear things up and does the magic of putting these things together for someone who's been seeking that help for years and years. So thank you all for watching. Hope you learned something. Please subscribe. And next time Dr. Markuson comes on, we're going to be talking about what every doctor needs to know about RSI. So you won't want to miss that. See you next time.
Thanks.